Hi, welcome. My name is Ewen Griffiths. I'm a consultant upper GI surgeon in Birmingham. It gives me great pleasure to present this talk on the effect of um, surgical complications on the esophagogastric cancer surgeon. This is effectively results of a survey exploring the impact of these complications on professional and personal life. Credit goes to Svetlana, Sivesh and Richard, but particularly Svetlana who did this, and she's now off on maternity leave and didn't have a chance to present this in Brisbane this year. I've got no disclosures. Um, this is one of my favourite talks about the esophagus. When the esophagus is sutured, a long period of patient care awaits us. And this was said by Ambrose Paré in the 1500s. And he was applying this sort of quote from repairing injuries of cervical esophaguses during wartime, but it applies equally today in the era of minimal access and robotic esophagectomy. And it also alludes to the anxiety that surgeons face when waiting for joins and anastomoses to heal. So we all know that esophagectomy is a high morbidity and high mortality procedure. Um, no previous studies have particularly assessed the psychological or emotional effects of complications on the primary surgeon, specifically doing esophagectomy. There have been other studies in colorectal or general or bariatric, but nothing specific in esophagectomy. And this alludes to the second victim phenomenon. Obviously, the first victim is the patient, but it's well recognised in healthcare settings that the second victim, nurses, anaesthetists, other people looking after patients who undergo complications, have significant psychological and emotional trauma. So our aims were to explore these effects of complications on practicing OG cancer surgeons, trying to identify systems and support required, and really to try and develop a foundation for the development of more structured support within the esophagogastric community. The methods were we did a cross-sectional anonymous online survey using the esophagogastric anastomosis audit email addresses. We aimed to specifically survey qualified consultants or attending surgeons. And we developed a 32 question survey divided into 5 themes of baseline characteristics, experience with postoperative complications, the impact of the complications, support mechanisms, and any medical legal issues that arised. And this was collected on a simple Google form. We received 101 responses. We excluded one because it was from a keen medical student who clearly hadn't done esophagectomy. We had 14% females, 86% were males. The median number of esophagectomies per year in the unit was 50, and the median number of esophagectomies per surgeon was 18 per year. We had respondents from 30 countries, the majority of which were in UK, United States, Netherlands, Germany, Australia and Turkey. We asked surgeons what complications they had experienced. 43% had suffered a tracheobronchial injury, 36% had suffered major intraoperative bleeding, 20% had injured the bowel, 35% had injured the spleen, 13% had an intraoperative death, 11% had not yet had an anastomotic leak to use endoscopic intervention with, 64% had a bad anastomotic leak requiring a reoperation, and 39% had a gastric conduit necrosis requiring esophagostomy. 58% had injured a recurrent laryngeal nerve, 40% had an acute diaphragmatic hernia, 75% had a car leak, 43% had a major reoperation for anything other than bleeding. 74% had patients reintubated due to pneumonia, and there was other issues as well, including 67% had a patient die after surgery. We asked them what emotions were experienced by the surgeon following these complications, and as you'd expect, these were anxiety, worry, frustration, disappointment, fear, embarrassment, anger, despair, sadness, and also depression. We also asked about the effects of the complication had on the work as experienced by the surgeon. 43% said nothing affected them. 19 did some dual operating. 18 performed some parts of the procedure under supervision. 12 undertook more training. 5 changed their work rota to improve things. 2 took time off work, and 2 stopped doing esophagectomy procedures altogether. We asked about support, which was sought by 71% of participants in the survey, and the majority of this, 50%, was from colleagues in the hospital, 30% were from friends and family, 17% from external colleagues, 15 had formal mentoring, 13% had training or courses, and a minority had psychological or counselling support. We asked about medical legal issues. 25% had appeared before a coroner or a medical examiner. 6% had a medical legal case against them about esophagectomy complications. We also asked about the future family and patient dynamics after the complication. Luckily, 83% of families and patients were understanding. 73% continued to trust the surgeon, but 15% had unpleasant behaviour from the families. 10% had a breakdown in doctor-family relationship. 9% had formal complaints, and 6% had asked for a formal request for transfer of care to another surgeon. There's obviously limitations to this survey. It's got a limited sample size. There's obviously selection bias in who replied to the survey, and there's also potentially recall bias because we're asking surgeons to recall complications from the past. But nonetheless, complications have a considerable impact on surgeons' professional and personal well-being. We feel that esophageal surgeons may face distinct challenges given the high morbidity and mortality of this operation, and this perhaps necessitates specialised support for some surgeons. And there's obviously a clear need for improved support and recognition of the effects of complications on surgeons who carry out these difficult and demanding operations. I'd like to finish here, but I'm very happy to take any questions. Thanks again for allowing me to present today. Thank you.